Hi, this is Dr. Dan Sullivan with the Sullivan Group, and this is a short demonstration of a new AI-driven emergency medicine risk and patient safety program called ED Guidance, co-developed by Nuance and the Sullivan Group. ED Guidance lives inside of Nuance's Dragon Medical Advisor and evaluates your medical record real-time during the patient encounter, offering guidance focused on improving diagnostic certainty, reducing medical errors, and keeping our patients safe. ED Guidance works with the most popular electronic health record systems. ED Guidance lives outside of and communicates with everything inside the four walls of your medical record, regardless of how the information enters the chart. You may place it in any location that's convenient for you. You can float it, dock it right or left. Or the favored workflow for practitioners with two monitors is to open it at the beginning of the shift, move it to the second monitor, and just let it follow you from patient to patient. For now, let's dock it right, and I will show you other potential workflows after this first patient. Insert ED note. I will use some macros and some dictation to move quickly through the chart. The patient is a 20-year-old male with severe back pain, period. ED Guidance will now evaluate the medical record real time and through a series of algorithms provide a list of conditional clinical drivers that TSG has developed over the last 2 decades. Clinical alignment around the drivers is known to be associated with a reduction in medical errors and malpractice claims. After review of tens of thousands of ED claims, these are the critical elements that can lead to a correct diagnosis but are often overlooked or missed, resulting in medical error and the failure to diagnose. Think of ED Guidance as a checklist. There is nothing required, no hard stops, there is no change to your current workflow, just suggestions that could make a significant difference. This patient presents a good example. This is an actual case of failure to diagnose spinal epidural abscess. What is the risk profile here? It is anchoring on musculoskeletal back pain and failing to consider more serious problems in the differential. In this case, the possibility of spinal epidural abscess cauda equina syndrome and acute aortic dissection. So let's make our chart. Back pain history 1. Onset of pain was gradual, typical, not dangerous. That will retire. I was reminded to ask about movement or migration of pain for acute aortic dissection. There wasn't any. That just retired. Now I'll give the patient something a little unusual by design. This will not happen often, but I want to show you some of the functionality of the program. The pain is located in both the lumbar and thoracic areas, period, new paragraph. So that's location of pain, and that will retire. But the algorithm will see the 2 levels of pain and will now suggest the possibility of consideration in the differential diagnosis of a spinal epidural process. Don't know what it is at this point. Also just dropped in conditional guidance in case the practitioner wants to review risk factors for a spinal epidural process. Back pain history 3. Mechanism of injury was lifting. That retires. I thought about incontinence, bowel and bladder for cauda equina, and that just retired. I was reminded to ask about fever, which is very common miss in failure to diagnose spinal epidural abscess. Think consideration of fever in the history. In this case, the patient has a fever, has 2 levels of pain, and so now the program is suggesting a consideration of the possibility of a spinal epidural abscess in the differential diagnosis. Another important part of this program is decision support inside the user interface. We believe that we don't need it very often, but if you do need it, you shouldn't go to your cell phone or do an independent internet search. Those resources should be available inside the user interface and immediately available. In this case, this is a quick consult on spinal epidural abscess, key history, key physical exam, clinical risk and safety pearls. We think if you need a resource, it should be available, sort of 80-20 rule. We've been doing this for 20 years. We're providing resources you would need for a back pain patient. If you need something in addition, let us know and we'll add it to the list. Another interesting thing about this program is the American Medical Association and the ACCME are very invested in practitioners getting CME for point of care resources. So when this practitioner is a 20-year-old with back pain that went to the internet and it returned guidance and these resources. And so this practitioner just got zero point 0.5 Category 1 Internet Point of Care CME, which can be claimed at any later time, just the same way you would do it on Medscape, Doximity, or UpToDate. Another important part of this program is recall assistance. Here we're just reminding the practitioner, don't forget your back exam, don't forget your neuro exam, but we forget lists of things, oftentimes lists of risk factors, and so they are listed here specifically for recall assistance. There's been no prior epidural bleed, patient's not on anticoagulants, there's no bleeding disorder, no recent spinal procedures, period. There are no risk factors for spinal epidural abscess, period. The platform is smart enough to get them individually or by saying they're negative, they're positive, reviewed, or unknown, and they will retire. Back pain review of systems, back pain physical exam, back examination is normal, there's no spinal or paravertebral tenderness, period. The last thing in this workflow is the neurologic examination. Now this might be a neuro case because it's a back pain case. There might be spinal injury. We may need to correlate our physical exam, or our APP or resident may need to correlate their physical exam with some level of spinal injury. Difficult to do. Again, resources are immediately available for things that are so easy to forget. What part of the body is associated with what part of the spine, or if the practitioner wants to use a dermatome map, nobody remembers the dermatome, so they are built in for immediate availability. The last thing on the neuro examination is we teach our residents to do a complete exam of the relevant organ system. And so many times in these current EHRs, dropping in macros, we often see something like this. Neurologic examination is normal, period. But that's not enough in a case like this. That's not a complete exam of the relevant organ system. So this is a smart platform. We taught it sensory, we taught it motor, we taught it DTR, straight leg, raise and cauda equina, and then we can dial in how many we believe are or represent a complete exam of the relevant organ system. So now we have it set for 3, but we could absolutely do 4 or 5. So this will retire the neurologic exam. On neurologic examination, there are no sensory or motor focal deficits, deep tendon reflexes are normal, and straight leg raise is negative, period. A neurologic exam will retire, and me alone, or me and my advanced practice provider, me and my resident, the team, we have clinical alignment, standardization, decreased variability on these key elements, these key diagnostic drivers in a back pain case. All right, for the purpose of this first demonstration, I left the ED guidance window open, but let's talk about other potential workflows. You may be working on a single monitor and want to make your record with ED guidance closed. Close Advisor. In the electronic health record, real estate is precious. Let's go to the trackboard and change patients and do a similar case. Back pain demo 2. With ED guidance closed, it is important for the practitioner to be aware that guidance is available. Whenever guidance becomes available, you will see a guidance preview that will appear for 10 seconds and then disappear. You can then open guidance with a voice command, run Advisor, or open it with a designated button on your power mic. Here, you're using ED guidance as a sort of a spell check at the end of the encounter. You will only see the guidance that remains, in this case, fever by history. You can then go anywhere in the medical record to address the issue. Patient has had a fever with shaking chills over the last 2 weeks, period. That will then retire fever by history, get that clinical alignment, plus you get that reminder to be thinking about the possibility of a spinal epidural abscess because of the fever, reminded about the risk factors. Patient admits IV drug use, period. And in this case, are probably now thinking of both musculoskeletal back pain and a possible spinal epidural abscess in the differential diagnosis. Close Advisor. Let's do another workflow where a scribe has created the chart and shares it with you for review. Let's change to a child with a fever, child with fever demo. Or maybe you're working with an advanced practice provider and the chart needs your review and signature. The guidance preview appears, so some critical documentation has been overlooked. Otherwise, it would not appear. Run Advisor. You can go anywhere in the record and address the guidance, or even create a second note on the patient, and ED Guidance will interpret both records. Here I will go into the medical decision-making section. On physical examination, the neck examination was normal, common normal range of motion, period. There were no meningeal signs, period. The child was vomiting at home, so we provided an oral challenge, period. The child tolerated both the food and fluid oral challenge, period. Again, now we have that clinical alignment, that decreased variability. You want to be certain to create a chart establishing wellness prior to discharge in every febrile child presentation. Let's dock guidance to the right, and let's do this last workflow on a 42-year-old with chest pain. Chest pain demo 1. ED Guidance has a strong focus on medical decision making. As you can see, the practitioner did not address all the guidance. Let's just address the hemoptysis. Patient has shortness of breath and hemoptysis, period. Hemoptysis will now retire, and conditional guidance will now appear for PE risk stratification. Note that the calculators are immediately available to risk stratify. Let's open Wells. Wells is available. The answers are immediately answered no. Change it to yes, obviously, as appropriate. But if all no, then the note is actually in the calculator. Copy those results into the chart. If you're using PERC for your algorithm, flip over to PERC. Those are all pre-answered no. If they're all no, copy that into your medical record. So that's ED Guidance. And thank you for taking the time to watch this video. ED Guidance used by your group, hospital, or organization will result in clinical alignment around these key clinical drivers, provide immediate access to decision support, provide most of your annual CME requirements, improve diagnostic certainty, reduce medical errors and related malpractice claims, and most importantly, keep our patients safe. Thank you.